So welcome everybody. Peter, it's really nice to see you again,
Good to be
as
here.
always. Um, so I thought maybe we should just kick off. Let's start from the UK and then build out in concentric circles from there. Give us your sense of where we're at in the pandemic, um, approaching peak, close to peak. Tell me what you're hearing, both from people who you know in the public health sector and also just from what you've been reading and seeing on numbers.
Sure. So, hi everyone. Good to see you all, and thanks for joining. We are here in the UK plateauing, it appears. Now, remember, following the number of cases is a little bit difficult because we're under testing and the kind of protocols are changing. And so, following the number of reported deaths and hospitalizations, where we can get that information, is probably a little bit more useful. So, what we've seen now that we are about 3.5 weeks into the kind of official quote unquote lockdown, and close to 4 weeks since there was really significant social distancing, that we definitely are seeing the fruits of everyone's effort there, in that if you just take the number of daily reported deaths, that seems to have sort of plateaued at about 750 per day. So you can say, yay, plateau, and then take a minute to understand that 750 people lost their lives yesterday and are again today. And so it's still a tragic toll. What we've seen elsewhere, and I think we seem to be following suit here, is that this notion of peaking isn't sort of like you go up and you peak and then you come down. There's really kind of a plateauing that can sort of hang around for a bit. So we've been sort of in the same range in terms of the number of deaths for several days now, and I expect that that will sort of continue. And then hopefully, assuming we keep the same kinds of measures in place, that will start to then taper off. And it's going to probably take a couple of weeks before things will drop down significantly, but certainly this is at least a positive sign.
Now tell us, I mean, part of counting deaths as a kind of tragic but somewhat more accurate way of assessing the true impact of the pandemic is in fact predicated on those death numbers themselves being properly recorded. And before we went live, you were saying, the kind of looming scandal, maybe not, but real problem with properly recording and acknowledging deaths in care homes, and a kind of underreported tragedy playing itself out there. Tell us a little more about that.
Yeah, scandal was my word, not your word. I'll talk about why. At least I think that's the case. So first off, for weeks we've all been saying, don't focus so much on cases, focus on deaths, because our assumption would be those would be a pretty accurate figure, because it's hard for a death to go unnoticed. But it turns out, of course, a death can go unnoticed but unreported for a variety of different reasons, right? One is that if someone dies of a COVID-like illness but isn't getting tested because testing is not accessible, they may not be counted in official figures. So you may have seen in the news yesterday that New York City, which of course has been a real epicenter for the pandemic over the last several weeks, adjusted their reporting and included all probable cases of COVID-19. These are people who had exposures and COVID-like symptoms who died but never got tested because of shortfalls in the availability of testing largely. And they added 3,700 deaths to their totals, which increased the full death toll by about 50% in one day. Now, of course, that was a backlog of several weeks of reports, but it was because people weren't getting tested. So you take that same mentality and you say, okay, what's going on here? We know that policy in the UK is that you only get tested if you're hospitalized, and then maybe if you're a health worker. Everybody else in the community can't, right? So what's happening to all of those folks? And are there people who are dying outside of hospitals who are not being counted? And the place to be real concerned about are any kind of long-term care facilities like care homes. Across Europe, in a study the other day that looked at Belgium, France, Italy, a couple of other countries in Europe, suggested that up to 50% of all COVID-19 deaths are actually occurring in care homes. Why? You have obviously very elderly people, oftentimes with other diseases, the most vulnerable amongst all of us to this particular disease. They're living in close proximity in kind of an institutionalized setting, and they're convening in small spaces and dining halls and things like that. So in some ways, they're like stationary cruise ships, right? With the most kind of vulnerable people. Unfortunately, we haven't been as attentive to those risks as we have in hospitals. And so care workers in care homes are not getting PPE at all, and other measures haven't been taken. So we're seeing now reports that at least 2,000 care homes across the UK have cases. And the first estimate of how many people are dying in care homes because they've not been included, right? The tolls that we see every day, the 750 or so deaths reported per day, are only in hospital deaths. We know as of today, there have been at least 1,200 additional deaths in care homes. My suspicion is that that's actually an underestimate and just a kind of a first estimate, but that number will go up. So what's happening right now is we're really seeing a deadly silent spread of this disease through many of those facilities across the country and across Europe. And it's clear we haven't done enough, both to protect healthcare workers in those settings and, our most vulnerable.
So
that's why I called it the scandal.
Yeah, no, and I mean, I think that has all the definitional requirements of scandal. So I'm in some ways, the more we're in this, the more I begin to think that this disease is a mirror that shows us about our society, but it's a mirror that's also a magnifying glass. It sort of accentuates the things that pre-exist. So when you have inequality, it exacerbates it. When you have racial disparities, it exacerbates it. When you have the elderly who are treated poorly and institutionalized, it exacerbates it. So let me ask you two related questions. The first is, the care home problem strikes me as a particularly devilish one, because in some ways, elderly people who don't have a tremendous amount of people to advocate for them. I mean, obviously they have their children and their offspring, but in some ways, who are coming to the ends of their lives, they run the risk of being dispensable statistics and not a particularly salient or politically powerful group of people. They're also confined to homes, so they're not really spreading the problem. They're just targets of it. So is that who is going to be advocating for this group, particularly because I think in a sort of rough cost-benefit calculus, you can plateau and continue to plateau, and you can still have this death ripping through care homes. And from a broad public health and reopening perspective, you can kind of not make that much of a difference. Is that a fair analysis?
Maybe. First, I want to just reflect on your earlier point, because I just think it's such an important one, this idea of the virus being a mirror and a magnifier of all of our existing problems. I think it's so important, right? This is just, the virus doesn't discriminate, but we do, something I've been saying again and again. And so it's thriving along our social fault lines and really exposing those in ways that are, devastating, but I think really important. And hopefully it's shining a light on dynamics that many of us know have existed for a long time, but others have found it convenient to sort of ignore. And we can hope something comes from that, and that we can use that sort of energy. With regard to the care home question, I think that, so yes, absolutely, they're elderly, they don't have much of a voice, they're cut off from their family members. And I'm sure, many viewers have family members who may be in care homes, or have sort of seen stories of folks who can't go and see their relatives there. There is a lot of spread happening within care homes. And so that's obviously a big issue, because this can spread like wildfire in any kind of institutional settings where you have people in close contact, just like the cruise ships. And you have healthcare workers that go, that care for those folks every day, that provide direct care, that prepare their food, that clean the facilities, etc. And they're all going home to their families every night as well. And they're not getting protective equipment from the government or from anybody else. Something we saw in Italy that was kind of underreported was that even after kind of the lockdown had been instituted and was starting to take effect, once you saw this crush in hospitals that overwhelmed the system, the hospitals themselves became epicenters of transmission between patients and healthcare workers and others that were sort of involved. And it actually probably spread out that plateau further because you were social distancing in lots of other places, but this is something where you were spreading like wildfire. And so to an extent, I think there is still a risk that if we don't try to contain things in those kinds of facilities, on top of obviously the moral hazard of that, it certainly could set us back in terms of kind of epidemic control.
Great. Let's pivot to across the ocean and talk about Trump and the WHO. And I'm going to try against all my instincts to ask a question which, against my better judgment, is there any modicum of a serious rationale at all if one took the best possible and most generous viewing of this action that just for the sake of argument would make it defensible, or is this just classic Trump?
Yeah, no, there's no merit. There's no merit to the move, and it'll hurt potentially a lot of people. It'll hurt Americans if this weakens WHO, because we need them now more than ever. So at its core, all this is a political blame game, right? This is simply the president trying to cast blame elsewhere to cover up for his own failings, right? Now, you can look, no one is coming out of this crisis unscathed or having done everything perfectly. And so you can look back to the way WHO handled this in the sort of the very early weeks in early January, and maybe didn't take as strong a posture in challenging China on some things early on when, as we now know, there was a little bit of cover-up happening, at least for a few weeks. That could have been different and that could have made a difference. But certainly by the last week of January, we're sounding the alarm, where it was declaring a public health emergency and was putting out really good, important advice. And had the U.S. follow those recommendations, it would be totally different, right? There's a new projection out today that suggests that if the U.S. had implemented the kind of social distancing stuff that they have 2 weeks earlier, 90% of the deaths thus far would have been averted, right? Because we would have been able to kind of trip the wire before you started climbing up that exponential growth curve. So, and that would have been early March, right? That's way after WHO was saying, this is serious, this could spread everywhere, everyone needs to take this seriously and start testing and tracing and distancing and things like that. So the US messed up badly. They're just trying to blame China and blame WHO to cover up for their own failings. And it's unfortunate to see WHO kind of caught up in this political fight right now, because they're needed elsewhere. This is taking root in the global south right now, and they're the only body that is helping kind of with the multilateral coordination and the global response. So if this hurts WHO, it'll hurt all of us.
And what will it actually mean for WHO? I mean, it means literally cutting off funding? Will it impair what they do right now? Will that gap be funded? Will the Europeans come in and sail to the rescue? But what's the real? You've been in the field and you've seen how these things work. What's likely to actually happen?
In the short run, from a funding perspective, probably nothing. Now, first off, the president doesn't have the actual direct authority to do this. If this money was sort of appropriated by Congress, technically he shouldn't just be able to say, I don't want to do this. In practice, they found ways around it just by slow rolling stuff. You think about the scandal with the military aid to Ukraine that got President Trump impeached last year. Similarly, they didn't have the power to do some of the stuff they did, but they just found ways to kind of slow roll. So there may be pushback from the US Congress, I don't know. And ultimately those monies may be released. It's also not like they're taking money out of WHO's bank account right now. US actually owes WHO a lot of money for sort of dues in arrears. So in the immediate short term, I don't think it'll hurt their balance sheet. And we'll see what happens with the US. We'll see whether others come in and pledge funding. The Gates Foundation is actually the second largest funder of WHO after the US government. What I think it does, though, is distracts a ton of attention and oxygen from WHO's actual work, which is helping to coordinate the global response and getting them sort of dragged down into the weeds, having to defend themselves. And it also really damages their authority. And remember, WHO has very little power. They have no enforcement power. They can't force countries to follow their recommendations or to do certain things. All they have is their kind of bully pulpit and their authority. And so when that authority is eroded, it could be quite harmful.
Can we talk a little bit about easing, kind of getting to the more hopeful part of our conversation? So you've seen sort of the kind of paradigmatic countries which have done well: Norway, Austria, New Zealand, and then you're beginning to see other places starting to talk about how you might ease or open up or dial back lockdowns in ways that might give us insights into what's effective and ineffective and wise and unwise in the UK. Tell us what you're seeing there.
Yeah, it's a really interesting time because a lot of countries are trying to figure out ways to open back up at least a little bit. And so I think big picture, one, that's a really good thing. Two, we should all get out of our minds that lockdown is a binary thing when you're in lockdown or you're out of lockdown, or that we're going to get back to normal anytime soon, right? This is going to be a gradual process and we're all stumbling in the dark a little bit. And I think we're going to be sort of learning. We hope we can avoid sort of cycles of lockdown, ease up, lockdown, ease up. But it's going to be a process. And we have some lessons from countries in Asia that started this, over the last month or two: South Korea, Taiwan, Japan, Singapore, now China as well. And we're starting to learn from European countries. So you mentioned a few, mostly smaller countries: Austria, Czech Republic, and then Norway, I guess not so small, as examples of countries that acted fairly early in terms of physical distancing and were able to kind of bend the curve successfully. They're already substantially kind of past their peak and are trying to find ways to open up. And they're all doing that in kind of slightly different ways. So no one is kind of opening everything back up. They're trying to open up certain key kinds of businesses. In some cases, they're experimenting with testing for immunity, or at least planning to do so, or at least for antibodies as a marker, as a marker of immunity. Austria is going to allow international travel. They're saying you can leave Austria now if you want to travel for business, but when you come back, you have to be quarantined for 14 days. So lots of little experiments. Spain, on the other hand, also began to ease their lockdown at the beginning of this week. That's much riskier because they're just barely kind of past that peak plateau period. And as of Monday, we're still recording 5,000 new cases per day. So there's a lot of active transmission in the country, and then you're opening things back up. And so it seems to me to be really risky in terms of a second surge in infections. And there's been mass confusion there about who's allowed to go back to work and who's not. And I think whenever you've got that kind of messaging confusion and such, it's just going to be a recipe for disaster. Briefly, criteria to think about, because if we bring this back to the UK, it's like, what can we learn? We'll see. I hope we're making a plan. We haven't heard anything like a plan from the UK government in terms of what comes next. They've essentially signaled that they're extending the lockdown for at least a few more weeks, but we haven't had anything clear about that. Certainly makes sense to do so. The sort of best planning that we've seen around this in general and the best thinking suggests a few different criteria. Number one, that you have a sustained decrease in the number of new infections. You've really bent the curve. You've had at least 14 days of declines. Here we might use deaths instead as a proxy for that, but that you've sort of substantially reduced the amount of active transmission that's happening. The lower that is, the better. You got to be way post-peak. So in the UK, in the best of circumstances, I guess we're about a month from there. Second, that your health system can cope and has a bit of surge capacity. So if you're still using like emergency procedures, volunteers, temporary hospitals and convention centers, you're not ready. If you've sort of been able to cope and you have enough healthcare workers and you have a little bit of surge capacity, if there was another surge, tick that box. And then third and fourth are kind of the testing and tracing, or testing, tracing, and isolation, that you're actually able to test enough people, anybody who has symptoms, and then anybody who's in contact with someone who has symptoms, that you can detect any kind of surge and contain it very early. So those are the things that sort of ideally would happen for a country to be able to safely start easing lockdowns. And if you have those things in place, there's a good chance that you can at least begin that process. Again, here, I don't know whether that's happening or not. We're still waiting for information.
So if you get to a point, say, I mean, every responsible government figure and politician is going to be driven, if they are going to be just objectively driven by data. And we're sitting at 750, tragic deaths a day. And in a month's time, we're at 100 deaths a day. And if there are 100 deaths a day, and as you keep telling us whenever we've spoken, you've got that kind of month league, which, leading up to it, once you hit 100, the kind of potentially, at that point, your hospitals can cope. You're not at surge, you're not in convention centers, you're able to flatten the curve. Does that mean that when you turn the taps back on, you can get absent proper contact tracing and testing, you're kind of just flying in the dark, and you're hoping that the epidemiological algorithm is going to the genie's not going to pop out of the bottle, because your rate of spread is so much lower than one that it just doesn't self-replicate, even if you take away the testing. And is that likely to happen?
Yeah, so it's the virus is going to be around in circulation whenever we decide we're going to be taking the next steps, right? So if we were to just go back to anything resembling normal amounts of sort of human interaction and human proximity, and don't do anything else, then absolutely the virus is going to start to spread and propagate again, and we'll sort of see those surges. The sort of ways that we can stop that are to be trying to stay way ahead of the curve. Now, contact tracing, for example, can be a really intensive process, and it's hard to sort of, because we've made no investments in setting up those systems, it's going to be hard to do well. Technology can help us with that a lot, and we've all heard about the Google and Apple apps that are under development. NHSX has developed its own, and so there's a role for that. It'd be nice to have an app. I'd be willing to give up some of my kind of personal privacy if there was an app that could ping me if I had come into contact with someone who then tested positive. But the fewer ongoing cases you have, the more your capacity is to actually do that, the more feasible it becomes, this idea of testing, tracing, and isolation. But we know that it takes time to ramp up testing. We know that it takes time to build an army of tracers and train them and get them going and things. And those things need to be happening now. The other thing we can do, obviously, to reduce the risk of a second surge is just be very careful about how we go back to normal life and exactly sort of what we ease. And here we're learning more about the kinds of interactions and the kinds of activities that seem to drive transmission more, right? We've learned that gatherings like church gatherings, parties, festivals, events that bring lots of disparate people into proximity for a period of hours was actually really important in driving transmission, much more than we thought before. You remember that on it was about March 13th, the Prime Minister and Patrick Vallance both said that canceling large gatherings would have no impact on the epidemic. It turns out that that's flat wrong. Those are going to be some of the last things to come back. But the question is, can some of us get back to work a little bit? Can kids get back to school a little bit? And we hope that's going to be the case. But if we start doing these things without testing and tracing in place, we're going to be flying in the dark. And that's a risk.
And let's just take the kids going back to school for a moment. So all kids go back to school. Schools are the definition of proximity. And then all kids come home. Now you can transmit asymptomatically, but kids are less vulnerable to actually succumbing to the virus, and presumably they're less apt to transmit asymptomatically.
We think. We don't have great evidence one way or the other.
But if that's not the case, if kids are good transmitters or as good as anybody else, then schools are about as, every school I've ever looked at with any of my kids, you see cheek by jowl and you jump up and down on each other in the playground, and
they're cesspools.
I think it's really hard to imagine them not being, right? So isn't just that act in and of itself, when you make that decision, just putting us back into very close to the equivalent of, anti-lockdown?
It might be. And this is something that people are modeling right now. And a couple of places are getting schools going again. And so I think we'll learn more from those experiments. And what's great is that we can then improve our modeling by taking actual data from real life. And so because different countries are doing this in different ways, hopefully that will allow us to learn from that experience. And what would be ideal is if we could sort of say, you brought your R naught down from 3. By the way, some people are saying it could be as high as 7, down to below 1, and stop this. What's the kind of marginal change from each one of these, different kinds of things if we were to open up schools, for example, if we were to allow for public transportation, et cetera. So we don't totally have that yet. It's all based on a lot of assumptions. And so there's a really wide kind of confidence interval about what any of that would do. Hopefully in the coming weeks, we'll get more information. Other thing to keep in mind is that, and this goes back to certainly something that's being talked about in the US a lot, where Trump wants to kind of just reopen the economy on May 1st. If people don't feel safe, they're not going to go back to work. They're not going to go back to restaurants. They're not going to send their kids back to school. So it's not like you can just switch the lights on and go back to normal, even if that was a good idea, right? Unless we have some confidence that we're going to be safe, we're not going to get back to any of that stuff, and the economy is going to continue to be hurt. And that's why we need a thoughtful plan, and to feel like we know that someone is in control and going to be helping to guide us through this.
So final question, in the spirit of getting to R naught, are treatments that can give people confidence that if they do get it, they're not going to die, they're just going to feel ill. Any modicum of hope out there that you've seen? And 2, I want to ask you a question around vaccines, because I know you've been upfront and close to that in your own personal capacity, but also just any other data or updates on that.
Yeah, so in terms of treatment, I guess the 2 big developments from the last several days, there's been a lot of hype around an old malaria drug called hydroxychloroquine. It's also used for autoimmune diseases as sort of a miracle cure. The sort of main trial of that was stopped because at the high doses needed to see if this works, a number of people had potentially fatal heart arrhythmias. And so that's been sort of pulled back and doesn't look like it's going to be a great option, at least as a treatment. At a lower dose as a preventive, maybe. And so some of those trials will be ongoing, but that's not going to be our miracle cure. There's an antiviral drug called remdesivir, which many of the viewers have probably heard of. It's been in the news. This was developed actually prior to Ebola, and then showed some activity in early trials in Ebola. What's good about it is that because it's been around for about 10 years, even though it's never been approved and quite found a use in a market, there's already a fair amount of safety testing. And so we know that it's typically safe in humans. The early kind of uncontrolled trials giving this to extremely sick people have been pretty positive if you look at sort of what happened to their clinical course and actually measure their viral load after they got it. It wasn't controlled, meaning you just gave it to everybody in an ICU who was really sick. and it kind of looked like a lot of them seemed to improve, but you're only going to know for sure if you can kind of randomize, some people to get it and some people not to get it. And so there are several of those trials that are now underway, like proper randomized controlled trials, including trials in people who are earlier on in the disease and less sick. So that's, could be really important. So we shouldn't put all our hopes on any one thing, of course, because it's uncertain and it might fail, but a little bit of early promise. And now we're to a stage where hopefully over the next month or so, we'll get some harder evidence about whether that is an option. So excited about that, excited about the plasma therapy, for essentially transfusing antibodies from recovered patients into either people sick with COVID-19 or health workers as kind of a preventive. Trials ongoing there as well. And there's every reason to believe that that's going to find at least a place as kind of a temporizing measure for us to save some lives until we get something better. And that something better probably still is a vaccine. So as you mentioned, I have sort of raised my hand to enter a vaccine trial that's being conducted here in Oxford. It's the first in the UK and one of dozens that are starting around the world. What it basically does is uses like a known vaccine vector, another virus that can't make you sick, and then you plug in some of the proteins that are like the signature proteins of the coronavirus on top of it to give the body like a signature and something to build antibodies to, but it can't make you sick. So we don't know yet if it works, and it's being kind of rushed through in really impressive ways in order to try to get this into human testing as quickly as possible. There's some risk to that because it's not been tested in animals yet, and a lot of other things that we would do that might take years are just being essentially skirted because we have some experience with the vector for this vaccine. I think that's a really good thing, right? Because we're trying to find ways to be nimble and to act quickly and to kind of balance the risk benefit given the urgency of the situation. So one of the things that's been really interesting for me in this process over the last couple of weeks have been watching they keep sending the updated information sheet and protocol every couple of days because it's changing all of the time. They're really like building this as they go. And as an entrepreneur, I love that, right? Because they are really trying to move and act and learn and improve and do the best they can as quickly as they can. I've never seen that in clinical research before. And given the circumstances, I find, maybe some people would be terrified that they have no idea what's going on. They just change the protocol. Again, I think that's terrific because they're trying to move fast. So they're going to roll 500 people and half will get the vaccine and half will get a placebo, another vaccine, and will be followed over time. I don't know whether I'll be selected for it or not. It was just for screening, but great to see, and great to see the machinery of our, awesome scientists in the UK being on the front lines of this. And as I mentioned, there are literally dozens of vaccines in development right now, a few of them in active trials, and even more importantly, some investment coming from Gates mostly in the kind of manufacturing capacity for some of the lead horses so that we sort of bet on the 4 or 5 that seem most promising. And let's build all the manufacturing capability so that just in case one of them works, we can quickly start making millions and millions of them. So some really forward thinking. That doesn't change the fact that we're still looking at a timeline that's probably 18 months, give or take. That's still world record time.
Still 18 months.
I mean, maybe 15 months now, because we've been saying 18 months for 3 months. Nothing is, again, that's still record time. And we have to have some humility because we had never had a vaccine for a coronavirus before. And we still don't know a ton about how much immunity you get from a vaccine or from being infected. We hope it's at least a year. And, a scenario in which there was an effective vaccine that we had to get every year, that's not a terrible place to be. That's like the flu shot. So we don't know. The reality is lots to be excited about, but we have to believe that we're going to be living with this virus in a way that's going to significantly alter our lives for certainly into 2021, which means a lot more briefings.
At which point I can hear the chitter chatter of beautiful children lurking around, to which you should return. So lovely to see you. Thanks as always for your time, and speak to you again soon. Thanks a lot.
Yeah, pleasure. Stay safe, everyone.
Stay safe and stay well. Bye bye.
Thank you.